faithfully conveying value by interpreting great books worldwide. Hello, this is Sally's Book Talk. Today I'm interpreting the book called A Guide to Women's Care with the subtitle Things You Must Know about Women's Matters. Due to differences in physiological structure, women naturally have many troubles different from men, such as vaginal discharge, menstruation, pregnancy, and some specific diseases, etc. What female-specific troubles do you know? Feel free to leave comments below. Some questions might make people feel too embarrassed to ask, or even lead to misunderstandings. For example, do you think girls who experience excruciating pain during every period are exaggerating? Do you think cervical erosion represents an unclean private life? Well, do you think women always bleed during their first sexual intercourse? Regarding the above questions, today's book has detailed answers for all of them. The book has 6 chapters, mainly discussing common issues in women's lives like vaginal discharge, menstruation, contraception, as well as over 20 common female diseases such as vaginitis, cervical cancer, ovarian diseases, helping you view the female body more scientifically and correct some misconceptions. The author of this book, Liu Chenglu, was a gynecologist at a top-tier hospital and started engaging with women's health in 2014. Since starting science popularization, she has published numerous women's health science contents on major social media platforms, with over 5 million followers across all platforms and was named one of Weibo's top 10 influential figures in 2019. Many people have benefited from her science content as a health and medical influencer. The author compiled her past science contents to create this book. Next, I'll explain the main content of this book in 2 parts. First, what body issues do women commonly encounter in life? Second, what common diseases do women have? Before starting the formal discussion, I'll briefly introduce the female body structure. The biggest difference between women and men in their bodies is the reproductive system. The female reproductive system mainly consists of the vulva and vagina, uterus, fallopian tubes, and ovaries. The vulva refers to the external part of the female genitalia connected to the uterus via the vagina. The uterus is located in the pelvic cavity, appearing as an inverted triangle from the front view. On the upper sides of the uterus, there are 2 slender curved tubes like wings called fallopian tubes. The end of the fallopian tubes is not closed but open to the pelvic cavity, spreading like an umbrella and close to the ovaries, able to pick up the eggs released by the ovaries. The notes include diagrams of the female reproductive system. Interested listeners can refer to them. All right, now that we understand the female anatomy, let's dive into today's main content. First, what body issues do women commonly encounter in daily life? I'll cover 5 aspects: vaginal discharge, menstruation, cervical ectropion, vulvar pigmentation, and the hymen. First, vaginal discharge. What is it? Vaginal discharge is secretion in the vagina, primarily composed of cervical mucus and shed epithelial cells, a normal bodily product. Present from infancy to adulthood. So what does normal discharge look like? If you search online, you'll likely find this answer: small amount, clear or white, sticky, odorless. But discharge isn't fixed. It changes throughout the menstrual cycle. During ovulation, rising estrogen makes it abundant and egg white-like. Post-ovulation, progesterone thickens it, sometimes turning yellowish. Near menstruation, pelvic congestion increases volume. Diet and environment also affect it. For example, dehydration may cause yellowness. Don't panic over minor changes. But greenish-yellow color, foul or fishy odor with itching, pain, or redness warrants attention. Possible infection signs. I'll elaborate on this later. Beyond discharge, menstruation is another universal female experience. What is menstruation? Some joke it's the uterus shedding lonely tears. There's truth here. Why? This stems from the uterus's purpose, nurturing new life. When an egg meets sperm, the fertilized embryo implants like a seed. The endometrium then acts as nutrient-rich soil, with vessels supplying nourishment. To prepare,
Post-ovulation hormones thicken the endometrium into fertile ground.
But if the egg doesn't meet its destined partner, it quietly withers away. The fully prepared endometrium then atrophies and sheds under hormonal influence. Combined with ruptured small blood vessels, this mixture forms menstrual flow expelled through the vagina, hence the lonely tears of the uterus.
So, what should normal menstruation look like? First, cycle length. Textbooks suggest 28 to 30 days between periods. This makes many assume deviations are abnormal.
Actually, regularity matters more than specific length. Cycles vary individually. Monthly, bi-monthly, or quarterly cycles are normal if consistent. Menstruation is easily affected by external factors like stress, diet, and emotions. Thus, cycles naturally fluctuate. Fluctuations within 1 week remain normal. For example, if your usual 28-day cycle shifts to 35 or 23 days occasionally, it's normal. But if cycles vary by over a week for 3 consecutive periods, medical consultation is advised. Second, flow volume. Clinically, 5 to 80 milliliters per period is normal. Estimating with pads. Soaking over 30 full pads may indicate heavy flow.
Conversely, needing only panty liners suggests light flow.
Like cycle length, flow volume can be affected by external factors. Occasional changes shouldn't cause concern, but persistently abnormal flow, especially heavy periods causing anemia, warrants medical attention.
Lastly, color. Typically dark red. Some women pass black clots, mistakenly believing they're toxins.
Actually, it's just blood pooling and coagulating in the uterus, unrelated to detoxification. Common among sedentary individuals, those with tilted uteruses or heavy flow. The most troublesome issue for women during menstruation is dysmenorrhea, which is categorized into primary dysmenorrhea and secondary dysmenorrhea. First, primary dysmenorrhea. During menstruation, the uterus contracts its muscles to expel blood and shed endometrial lining from the uterine cavity.
These contracting muscles compress blood vessels, causing uterine ischemia, which leads to pain.
Simultaneously, in the shed endometrial lining, there's a substance called prostaglandins that promotes uterine contractions, intensifying the pain. Prostaglandins are active substances with various physiological functions found in nearly all human tissues, but they were first discovered in semen, and people thought they came from the prostate, hence the name prostaglandins. What do women around you usually do when experiencing dysmenorrhea? Most people probably opt for heat application or drinking warm water. This relaxes tense blood vessels, speeds up blood circulation, and disperses prostaglandins accumulated in the pelvic area, helping alleviate pain, though the effect is slow and limited. Besides this approach, there are 2 other methods to try.
The first is oral antipyretic analgesics, like ibuprofen or naproxen.
These medications inhibit prostaglandin production, but it's best to start taking them 1 or 2 days before menstruation. Take them until the dysmenorrhea ends. If the pain is severe, try starting 2 to 3 days before your period. Continue this for 3 consecutive months, then stop in the 4th month. Some people may experience relief from dysmenorrhea. The second method is oral short-acting contraceptive pills. These pills contain estrogen and progesterone, suppressing ovulation, controlling bleeding, and reducing pain.
They also regulate the menstrual cycle and can delay periods, making them suitable for those with dysmenorrhea plus abnormal flow or irregular cycles.
Important: don't confuse short-acting pills with emergency contraception. Always consult a doctor about usage. Never self-medicate. Compared to primary dysmenorrhea, in contrast, secondary dysmenorrhea causes more intense pain, even unbearable agony. Causes of secondary dysmenorrhea include endometriosis, adenomyosis, uterine fibroids, congenital malformations, etc. These all require a doctor's diagnosis. Let's cover the most common one: endometriosis. As the name implies, endometrial tissue appears in abnormal locations outside the uterine cavity. If on the ovaries, it causes chocolate cysts. This is because the accumulated menstrual blood in the cyst resembles liquid chocolate. During menstruation, the atopic endometrial tissue on the ovaries sheds along with normal endometrium, but without drainage channels on the ovaries, the shed tissue and blood can't exit normally like uterine menstrual blood. Instead, they form cysts that rely on self-absorption. Limited absorption capacity causes increasing pain during each period, sometimes untreatable by painkillers, that subsides after menstruation. If someone around you experiences this, medical consultation is recommended. Doctors will perform tests to confirm diagnosis and recommend medication or surgical treatment. The third common issue women face is cervical ectropion. Hearing the term erosion, does it sound frightening? Have you associated it with promiscuity? Actually, cervical erosion was removed from medical textbooks in 2008. It's not a disease requiring treatment, nor is it linked to sexual behavior, cervicitis, or cervical cancer. It's a normal physiological state.
Now termed cervical ectropion. How does this change occur?
The vagina connects to the uterus via the cervix, which has two epithelial cell types: outer, smooth and durable cells, and inner, red and bumpy cells like bayberries. Their shifting boundary resembles a coastline, moving like tides. Before puberty, women have low estrogen levels. The boundary stays inward, exposing smoother cervical cells. After maturation, rising estrogen pushes the boundary outward. This reveals the bumpy epithelium, cervical ectropion. Post-menopause, the boundary retreats inward, restoring the cervix's smooth appearance. Though this resembles true precancerous cervical lesions visually, clinicians usually recommend additional tests to rule out other conditions. The fourth issue women might mention in daily life is the color of their intimate areas. There are always rumors online that if a woman's areola or vulva is dark, it indicates extensive sexual experience.
Actually, there's absolutely no connection between the two.
What truly affects the color of intimate areas, besides genetic factors, is primarily the level of sex hormones. Compared to other areas, the skin in intimate regions has more melanocytes, which are sensitive to sex hormones, making it easier for melanin to deposit there. Before puberty, women have low sex hormone levels, so their intimate areas have minimal pigment deposition, appearing light pink. After maturation, as sex hormone levels rise, the color of intimate areas gradually darkens, a normal physiological process. The fifth issue concerning women is the hymen. What is the hymen? In traditional beliefs, the hymen is often imbued with sacred significance. Many people believe that during a woman's first intercourse, the hymen must rupture and bleed. But in reality, for most women, the hymen ruptures long before puberty. At birth, the hymen is located deep in the vagina, usually without an opening, serving to protect the reproductive organs. With age, the hymen gradually thins and enlarges like rolling out dumpling dough and moves outward toward the vaginal opening. When it becomes very thin, an opening forms, typically about 2.5 centimeters, allowing menstrual flow to exit. If no opening forms, it can cause menstrual blood to be trapped during puberty, leading to cyclical abdominal pain, masses, and other issues. During first intercourse, the hymen may rupture again due to force and bleed. If the existing opening is large or the hymen is thicker, it may not rupture or bleed. Statistics show that only about half of women in China experience visible bleeding during their first intercourse. Many people obsess over whether the hymen is intact, leading to the development of a surgery called hymenplasty. This surgery is relatively simple, with three main methods. First, directly stitching the remaining hymen together. Second, pulling the vaginal mucosa up and stitching it together. Third, implanting an artificial hymen. Although the procedure is simple, it's important to note that surgery may cause scarring, similar to scars formed after skin injuries. Scars are generally tough and may thicken and enlarge, causing vaginal stenosis and difficulty during intercourse. And beyond daily concerns, gynecological diseases also frequently trouble women. Now, let's discuss the book's second part, What common diseases do women face? I'll cover 6 aspects: gynecological inflammation, uterine fibroids, abnormal pregnancy, cervical cancer, ovarian diseases, and pelvic floor dysfunction. When mentioning gynecological diseases, many first think of inflammation, including vulvitis, vaginitis, cervicitis, endometritis, pelvic inflammatory disease, etc. Among these, vaginitis is the most frequently discussed. Vaginitis falls into 2 categories, one caused by imbalance of the vaginal flora, the other caused by external pathogens entering the vagina. Let's explore each separately.
First, inflammation from flora imbalance, primarily bacterial vaginosis.
The vagina naturally hosts various microorganisms. Normally, these flora maintain a balanced coexistence, surviving without overproliferation. Disrupting this balance causes bacterial vaginosis, characterized by increased, thin, grayish-white discharge, occasionally with small bubbles, fishy odor, and mild vulvar itching. Causes include introducing external bacteria during intercourse and poor hygiene habits. Thus, maintain good hygiene during intimacy and daily life, but avoid over-cleaning extremes. We often see various feminine washes in supermarkets, pharmacies, and ads. This misleads many into believing these washes are essential for cleanliness. Actually, this is misguided. Vaginal douching easily disrupts flora balance and causes bacterial vaginosis.
For daily hygiene, simply rinse the vulva with water and keep it dry.
If diagnosed with a condition, use medicated washes only under medical guidance, never self-prescribed. The second category involves external pathogens, like trichomonal vaginitis or fungal vaginitis. Trichomonal vaginitis, caused by Trichomonas vaginitis, spreads directly through sex or indirectly via shared items like pools, towels, or toilets. Symptoms include yellowish-green, thin, pus-filled discharge that's foamy like rice water, with a foul odor. Treatment usually involves metronidazole, with both partners requiring simultaneous therapy. Fungal vaginitis features cottage cheese-like discharge and intense vulvar itching, caused by candida, a fungus treated with antifungal medication. Common antibiotics target bacteria and won't help pure fungal infections. Never misuse them. The second common disease category is uterine fibroids. Uterine fibroids are the most common benign tumors in female reproductive organs, rarely turning malignant, mainly caused by smooth muscle cell overgrowth. Estrogen is the primary growth driver. Fibroids in different locations may press on bladder or rectum when large, causing frequent urination or constipation.
Intramural or submucosal fibroids increase discharge, menstrual flow, and duration, often leading to anemia from blood loss.
What to do if fibroids are found?
If asymptomatic with no cancer risk, just monitor. For treatment, 3 options. First, estrogen-suppressing drugs to inhibit growth.
Second, surgery, myomectomy, hysterectomy, or uterine artery embolization, chosen case by case.
Third, focused ultrasound therapy, using sound waves to destroy fibroid cells.
Each method has pros and cons. Weigh options under medical guidance. The third common female disease category is abnormal pregnancy. In single quotation mark, only the doctor knows. Author Jiang Yu shares a story. A young girl with 7 to 8 days delayed period sought painkillers for cramps. Soon after, she said she needed to defecate and went to the restroom.
10 minutes later, she was found pale and unconscious there.
After resuscitation, she recovered. She was a classic ectopic pregnancy rupture case, where pregnancy occurs outside the uterus. Simply put, fallopian tubes are 8 to 15 centimeters uneven width tubes, winging from the uterus, with fimbriae that sweep released eggs. After the egg and sperm unite in the outer part of the fallopian tube, they travel along the tube toward the uterus. If the tube has inflammation, twisting, or adhesions, the fertilized egg may get stuck and implant along the way instead of reaching the uterus. This causes an ectopic pregnancy in the tube. Fallopian tubes are narrow, with thin walls and rich blood supply.
Around 6 to 8 weeks after a missed period, the tubal pregnancy can rupture,
causing massive bleeding.
That girl's urge to defecate was caused by initial tubal rupture and blood pooling in her pelvis. Also, the bleeding she thought was her period wasn't menstruation, it was abnormal bleeding from the ectopic pregnancy. Besides ectopic pregnancy, molar pregnancy can occur. A molar pregnancy lacks normal fetal tissue, instead forming grape-like clusters of vesicles diagnosable by ultrasound. Most molar pregnancy patients experience vaginal bleeding around 8 to 12 weeks post-missed period, with more severe and prolonged morning sickness. Molar pregnancies are mainly caused by abnormal sperm chromosome expression, but may also relate to maternal nutrition, age, and other factors. Once diagnosed, immediate hospitalization for uterine evacuation and follow-up as directed is crucial. Many require multiple evacuations or even chemotherapy to ensure a complete cure. The fourth category of common female diseases is cervical cancer. Cervical cancer is now the second biggest threat to women's lives, just after breast cancer. Before cervical cancer develops, there's a precancerous stage. Active treatment at this stage can prevent cancer, though many show no symptoms, making regular screenings vital. Even with cancer, early treatment has excellent outcomes.
Recently, HP vaccination has become popular. This vaccine prevents HPV, which causes 90% of cervical cancers worldwide.
So we can say this is a human innovation. As the first cancer-preventing vaccine, does HPV infection mean you'll get cervical cancer? And does HPV infection always require treatment? Actually, not necessarily. HPV is categorized into low-risk and high-risk types. Only high-risk infections may increase cervical cancer risk. High-risk HPV includes type 16, 18, 33, 52, 58, and others. Due to the body's immunity, HPV typically clears automatically within 8 to 24 months post-infection. Developing cervical cancer requires persistent high-risk HPV infection for 5 to 10 consecutive years. For example, testing positive for HPV-16 for 5 straight years. So a simple HPV infection doesn't guarantee cancer, doesn't always require treatment, and shouldn't disrupt your life. No need for undue anxiety. In China, HPV-16 and 18 are most strongly linked to cervical cancer. Available vaccines, bivalent, quadrivalent, and non-avalent, all cover these types. Beyond vaccination, regular HPV and cervical cytology tests enable early detection and prevention. The fifth category of common female diseases is ovarian disorders. As vital sites for ovulation and hormone secretion, ovaries hold immense significance for women. And many conditions can occur here, including corpus luteum rupture, ovarian cysts, polycystic ovary syndrome, PCOS, premature ovarian failure, and more, as the author notes. Now let's cover one potentially life-threatening disorder. Corpus luteum rupture. What is the corpus luteum? During a menstrual cycle, after ovulation, the egg's follicle transforms under hormones into a yellow structure called the corpus luteum, which secretes estrogen and progesterone. The corpus luteum matures about a week post-ovulation, typically 1 to 4 centimeters in size, sometimes reaching 8 to 9 centimeters. If pregnancy doesn't occur, it begins shrinking 9 to 10 days after ovulation. By day 14, it fully atrophies. Plunging hormone levels cause the endometrium to shed, triggering menstruation. If pregnancy occurs, it becomes the corpus luteum of pregnancy, secreting hormones to sustain gestation until it atrophies after 3 months. The corpus luteum is fragile with thin walls. Larger ones rupture easily under force. To prevent rupture, avoid external pressure around 1 week post-ovulation, roughly a week before your period, like intense exercise, straining during bowel movements, or rough intercourse. If a corpus luteum rupture occurs, seek immediate medical attention. Doctors will choose conservative treatment or surgery based on the situation. The sixth category of common female diseases is pelvic floor dysfunction. Many women after childbirth find they can't hold urine, especially when sneezing or coughing, or notice vaginal laxity, both related to this condition. 1. Statistics show over 30% of married Chinese mothers experience urinary incontinence. The female pelvic floor consists of multiple muscles forming a large web-like structure, providing stable support for urethra, vagina, bladder, uterus, and other organs. It regulates these organs' functions through contraction. During pregnancy, the fetus exerts continuous pressure on this muscular web, causing damage. Additionally, aging, pelvic surgeries, obesity, and other factors can damage pelvic muscles, leading to incontinence, vaginal laxity, uterine prolapse, or cystocele. What should you do if pelvic floor dysfunction occurs? The author mentions 3 approaches. First, pelvic floor exercises like Kegels. How to locate your pelvic floor muscles. Try stopping your urine mid-flow. The muscles you engage are your pelvic floor. Kegels involve consciously contracting these muscles. Start by lying down. Contract 50 times per set, completing 2 sets consecutively. Do this 3 to 4 times daily. Alternatively, hold contractions for 5 seconds, relax for 10 seconds, repeating 10 times per set. Practice 3 to 4 sets daily. Gradually increase intensity as you adapt. Consistent exercise for 6 weeks shows significant improvement. Important: never exercise while urinating. This increases UTI risk. The second treatment is medication, mainly estrogen creams, used under medical supervision. But medications have limited effects, only slowing progression and easing symptoms. Thus, for severe cases involving structural changes like uterine prolapse or cystocele, surgical intervention after medical evaluation is needed. That concludes the book's main content. As Spanish novelist Cervantes said, "The beginning of health is to know your disease and to willingly follow the prescription your doctor gives you." Treat your physical health with care. We often fear what we don't understand, yet we also become complacent due to ignorance. Arm yourself with science and knowledge so you stop worrying blindly or avoiding medical help. After listening to today's talk, what new insights do you have about women's troubles? Feel free to leave comments and discuss. A Guide to Women's Care.
That concludes our interpretation of this book for you.
Reading notes are below the audio. See you next time.